Today we will be discussing ischemia recognition in ECG. It will be a ECG, fully ECG based. And in the interactive session, participants can try to identify the ECG and see the abnormalities. Finally, we will correlate everything and will come to a diagnosis. You don't have to tell the diagnosis after seeing the ECG. You can just try to read it stepwise and then arrive at a diagnosis. The scope of today's discussion is acute coronary syndrome, basics understanding of STEMI, what is in STEMI, then concept of occlusio, which is a newly came concept in this STEMI and STEMI paradigm. Now it's occlusio. Both STEMI and INSTEMI will be included in that occlusio group. Culprit artery localization and identifying subtle ECG changes precedes STEMI and identifying STEMI mimics. It's all ECG based. So the basic understanding, there is a ACS always acute coronary syndrome is troponin elevation above the 99th percentile, and with the evidence of overt ischemia like angina, ECG, STT changes or Q waves, and echo abnormalities like regional wall motion abnormality, with the troponin rise or fall is accounting for myocardial infarction, and which can be type 2 or type 1. Type 1 is plaque rupture, which is usually causing STEMI and STEMI. That this is our today's topic of discussion. And this troponin elevation will always seen in other causes also, not in type 2 MI, where oxygen supply mismatch will be there, like tachycardias, arrhythmias, infection, severe anemia, shock, severe hypertension, arrhythmias. In this type 2 MI, type 2 MI with the mild CAD, there will be no infection pattern. And there will be also systemic symptoms also have troponin positive, but will not have overt ischemia like angina or STT changes. So everything will come under acute coronary syndrome. But today's discussion will be on type 1 myocardial infarction, where acute coronary syndrome leads to NSTEMI or STEMI. So in NSTEMI, what happens is the plaque, there will be some thrombosis. There will be no thrombosis, may not be always. So this thrombus will go and will cause some infection and
വോയിസ് ബ്രേക്ക് ആയിട്ടാണ് വരുന്നത് വിഷ്ണു. ഓഡിബിൾ അല്ലായിരുന്നു, വോയിസ് ബ്രേക്ക് ചെയ്യുന്നുണ്ടായിരുന്നു.
മാറ്റം
കാണുന്നുണ്ടോ?
ഇപ്പൊ കാണാം വിഷ്ണു. ഇടയ്ക്ക് ബ്രേക്ക് ആയിരുന്നു, വോയിസ് ബ്രേക്ക് ആയി, പിന്നെ വിഷ്ണുവിനെ കാണാതായിരുന്നു, സ്ലൈഡും കാണുന്നില്ല. ഹലോ വിഷ്ണു, കേക്കാവോ? ഹലോ സ്പീക്കർ ഇന്റർനെറ്റ് ഇഷ്യൂ ആണെന്ന് തോന്നുന്നു. അദ്ദേഹം ലോഗ് ഔട്ട് ആയിട്ടുണ്ട്, തിരിച്ച് ജോയിൻ ചെയ്യും ഇപ്പോൾ. സ്ക്രീൻ കാണാം വിഷ്ണു. ഹലോ വിഷ്ണു, സൗണ്ട് ഇല്ലേ? ഫസ്റ്റ് സ്ലൈഡ് കാണാം. ശബ്ദമില്ല, വോയിസ് ഇല്ല.
കേൾക്കാവോ?
ഇപ്പൊ കേക്കാം.
കേൾക്കാം.
ഒന്നുകൂടെ കേക്കാം.
ഒന്നുകൂടെ തുടങ്ങാമേ. ഇത് പറഞ്ഞില്ല, ഓക്കെ അല്ല. ടൈപ്പ് 1 MI നമ്മൾ എൻസ്റ്റമി അത് ഇത് കേൾക്കുന്നുണ്ടെന്ന് ഒന്ന് പറയണേ. ഒരു നെറ്റ്വർക്ക് ഇഷ്യൂ ഉണ്ട് ഇവിടെ.
കേക്കാം, ഇപ്പോൾ കേക്കാം, കുഴപ്പമില്ല.
ഓക്കെ. ഇതിനകത്ത് നമ്മൾ എൻസ്റ്റമിയും സ്റ്റെമിയും തമ്മിൽ ഡിഫറൻസ് ആണ്. അപ്പം എൻസ്റ്റമി ദർ വിൽ ബി പാർഷ്യൽ ഒക്ലൂസീവ് ത്രോംബസ്. ദർ വിൽ നോട്ട് ബി കംപ്ലീറ്റ് സെസേഷൻ ഓഫ് ഫ്ലോ, ആൻഡ് ദിസ് ത്രോംബസ് വിൽ ഹാവ് sometime it will go to distally and will go some small infections, and it will cause little bit flow limitation and cause ST segment depression and T-wave invasions. But it will cause chest pain, but the limit of infarction in the myocardium will be limited in STEMI. But in STEMI, there will be acute thrombotic occlusion, full cessation of flow, so that there will be necrosis of the myocardium will start at the earliest, and of cessation of flow, and there will be ST segment elevation. So this is the things behind NSTEMI and STEMI. In STEMI, there will be subocclusive thrombus, and most of the time it will be occlusive, but this distal vessel will be having collaterals from other vessels, or it will be preconditioned myocardium, so that it will survive ischemia a little longer time. But in STEMI, it will be acute thrombus. So how this ECG findings we see in STEMI? In STEMI, you usually see subendocardial ischemia, because subendocardium is the farthest and the most farthest from the coronary artery. So the coronary artery and the epicardium, it will penetrate and will go to the subendocardium. So it is the distalmost part of the myocardium which is perfused, which is the last perfused area. So whatever flow compromise happens, the subendocardium is affected. So subendocardial ischemia happens in subocclusive thrombus. But epicardium and mid myocardium will be preserved, and so the final injury vector will be from epicardium to endocardium. So whatever leads sitting here will see that current is going away from the lead, so it will be coming a negative deflection. So this ST depression will be there. But in in transmural infection like ST elevation MI, the entire thickness of the myocardium is lost. So when these areas normally depolarizes, the infarct myocardium depolarizes slowly, and the injury current will be recorded as ST segment elevation. Usually ST segment is an isoelectric segment like this. But when there's an injury and the voltage is this is getting slowly depolarized, that isoelectric segment is lost, and it will be recorded as a potential depolarization potential due to the slow depolarization in this ischemic region. So the ST elevation will be there. So there is a new paradigm concept, ST and STEMI. ST elevation, there is an occlusive MI, OMI or non-OMI paradigm. This is occlusive MI. Because why it is so? Because when we do angiograms in most of the Ischemia patients, they will also have occluded coronary arteries. There are coronary artery, half of them will have occluded coronary arteries, but that coronary artery will be perfused from the collaterals, or they have some mild and minor flow is there. So there is not to miss these patients. Now the new concept in 2024, they started is occlusive MI. So there is AI generated algorithm to find all these things. We will be seeing cases why this is important. Occlusive MI, why this STEMI and STEMI. I think we can. This is the STEMI criteria you all know. This is defined by the ECG mostly. At segment elevation at least 2 contiguous leads, and with at least 1 mm ST elevation. But in V2, V3, there will be 1.5 millimeter ST elevation in women and more than 2 in men over 40, and 2.5 in less than 40. And there is a STEMI is defined in the absence of LBB. In LBB, there is repolys abnormality, so ST will be elevated. And Q wave regarded as old or completed, in fact. This is the STEMI criteria. In OMI, we will see what is written in this at the right side. We'll see one ECG and understand what is the OMI, what is important like that. This is the just overview of troponins, how it's come into the diagnosis. Usually the troponin is the baseline ECG clinical feature plus troponin is the baseline of the diagnosis of acute MI. So high sensitivity troponin we are using. Some hospital use troponin I, troponin T, whatever it is, it's all sensitive to find out the early period of the infarction. So after an occlusion happens, ECG change, patient has chest pain, ECG changes comes in 15 to 30 minutes. Then enzymes start rising in 2 to 4 hours. So high intensity troponin T will be elevated after 2 hours. So usually you should at least follow one normal values. These all in picogram per liter. So usually if troponin T is followed, 14 to 22 is the norm. 14 less than 14 or is the normal range. Less than 22 for males and 14 for females. That is the normal troponin T levels. And if it goes to 100, we can. This is mild elevation. This can happen in fever or some sepsis on all other things. These are all non-MI injury because there is no infection, but some myocardial enzyme leak due to cell injury. In type 2 MI, there is oxygen supply mismatch. It will go up to 300, but it will not go above 300. And from 300 to 100,000 range, it will be it can be NSTEMI also. NSTEMI range it will go up to 1000. From 300 to 1000 can be NSTEMI range. From above 1000 onwards, it can be plate rupture. It can be STEMI range. So you should be knowing these ranges, or at least troponins for diagnosis of MI. So and we will go to ECG. I think today's discussion mainly depend on how to identify a ST elevation MI, how to identify the mimics of the ST elevation MI in different scenarios. So first, we'll go to the ECG. Can anyone read the ECG from basic? Can any of the listeners?
Participants unmute ചെയ്ത് ആൻസർ ചെയ്യാം കേട്ടോ. ശ്രമിക്കൂ.
You can just read it. I will help you to read it. That starting this ECG will start very systematically. Then we'll go fast because this ECG is abnormal. This is not a normal ECG. Most of the people be knowing the diagnosis also, but just we want to know how to diagnose this one. Why it's so like that. This is already started 3. This is 3 hour. We'll go by 3 hour, 2 hour, 1 hour, half an hour like changes from this ECG down onwards. So if you go fast, you can cover most of the ECGs.
Here this is an ECG, mild ST elevation and lead 1 AVL, V4, V5, V6. can be lateral MI.
It's anterolateral MI.
Anteroceptus lateral
So you can see the first
AVF.
Anterolateral.
You should first see the P wave followed by QRS, that is P wave in normal in lead to PR interval normal, QT interval normal, then ST segment we go. Then there are ST segment elevation is there. In this ST segment elevation 1 AVL, then V2 to V6.
കേൾക്കുന്നില്ല.
നെറ്റ്വർക്ക് ഇഷ്യൂ ആണെന്ന് തോന്നുന്നു.
ഇപ്പോ കേൾക്കാം,
കേൾക്കാം, പക്ഷെ സ്ലൈഡ് കാണുന്നില്ല.
സ്ലൈഡ് കാണുന്നില്ല.
നെറ്റ്വർക്ക് ഇഷ്യൂ ഉണ്ട് കുറച്ച്. ഇപ്പൊ കേൾക്കാം,
കേൾക്കാം, സ്ലൈഡ് ഇല്ല.
സ്ലൈഡ് കാണുന്നില്ല. ഇപ്പൊ ഷെയറിങ് വരുന്നുണ്ട്. കാണാം.
ശരി ശരി. Okay, this is anterolateral MI because of the because one AVL there is ST elevation. This ST elevation usually when we see how this progress is, there will be formation of Q. There is a V2, there is a Q wave. QS is there. QS. There is loss of R wave for V3, V4. There is R wave height will come down. QRS will come down, and the T wave will go up. It will go more than 25% of the QRS. Then there will be the reciprocal ST depression in V2. And then in this case, it is in inferior leads. There is this is a classical case of ST elevation myocardial infarction in anterior tertiary, LAD tertiary. So we will see how it is localized. So ECG in MI culprit artery, usually you also know there is 3 coronaries, LAD, left-handed descending, left circumflex, and right coronary artery. So the ECG leads which represents these territories are in septal V1 and V2. Septal is supplied by left-handed descending artery, and the entire septal myocardium as well as the anterior wall is supplied by the left-handed descending artery. V3 to V6, V3, V4 is anterior, V5, V6 almost in all LAD territory, distal LAD territory, and in 2-3 AVF. 2-3 AVF looks at the inferior part of the heart. It supplies the RCA. It looks at the RCA territory. So any change in the inferior leads 2-3 AVF, there is RC infarction, and lateral always mostly mainly by the diagonal or by the major obtuse marginal branch of the left circumflex artery. So lateral changes, one AVL or V5, V6, or sometimes inferior changes also can be seen in left circumflex coronary artery. So in proximal LAD occlusion, what is happened? How this ECG changes comes in that area, but because this all depend on the injury vector, because the myocardium which is injured will drive the ST elevation. So the ST elevation is in the leads which is looking directly into that area. So in proximal LAD, the proximal LAD occludes, then the septal as well as the diagonal as well as the mid distal entire LAD territory is occluded. So when we see what all areas are ischemic, in this diagram you can see the pink part, which is pink and red part. This is the infarcted myocardium. So whatever is young, this yellow color is the viable myocardium, which is supplied by the circumflex in this area, and this area is inferior, this RCA, right coronary artery. So entire septum as well as the anterior wall is ischemic in this. So there will be ST elevation we will be seeing in when AVL, then V2, V3, V4, V6 all leads, V4 lead till V4 leads, V3, V4 mainly. Septal is involved, so V1, V2 also will have anterior V3, V4, and AVL will have ST elevation, and corresponding ST depression will be seen in the leads looking below it. So 3 and AVF, 3 AVF, 2, 3 AVF. That's a proximal LAD occlusion. And this is the ECG of proximal LAD occlusion. You can see ST elevation in V1, V2, V3, and ST elevation AVL, 1 AVL also. And there is corresponding ST depression 2, 3 AVF, and sometimes in LCX set also V5, V6. Some usually we will see ST elevation V5, V6 also in this. Usually in this most of the cases, because all depend on the branching. More patients will be different in one on the other patients. If diagonal is giving this V5, V6, it will be also elevated in that area. So in anterolateral wall, only septal will be spared. So V1 septal will be spared, but diagonal and as well as mid to distal, all the other territories are ischemic. So you can see in this anterolateral wall MI, this one AVL ST elevation with the ST elevation in leads, anterior leads, two anterior leads like V3, V4, then V5, V6, because triangle is involved. And the corresponding ST depression will be seen in the inferior leads. Then in septal MI, there will be anteroseptal MI. In this V1 to V3, where will be still V3, V4 ST elevation and corresponding ST depression in lateral leads we will see. Because the injury vector will be on the because septum is mainly affected and the lateral wall will be spared. So one will depression, injury vector is below, directed below. So we'll have ST elevation in V1, V3 to V4. That order, V3, V4, and sometime inferior leads also it will be there 3, and depression will be seen in high lateral leads. And in distal LAD, territory usually is a little different, because all the leads looking into that area. So you'll see diffuse ST elevation entire V1 to V6 usually in apical infractions, one AVL also, because almost all the leads are represented in that area. So if you see a diffuse proximal LAD also can have, as well as apical infarction also, mid-apical infarction also will have almost all left one AVL plus V1 to V6 will have ST elevation. Sometimes inferior leads also will have ST elevation if wraparound LAD is there. So this apical area will have a diffuse ST elevation. So this is another example. This is first case we have seen a clear-cut ST elevation. This patient is 61-year-old lady and chest pain with 30 minutes time, because pain is typical. Can you enumerate the findings, abnormal findings in this ECG, or is a normal ECG? So this is a ECG you usually miss during evaluation. We will usually keep this patient for observation or repeat ECG. If you see at 1 hour after the ECG, there will be some findings. But at this point itself, you can find out some typical findings of ongoing ischemia in this ECG. Can anyone enumerate the findings? Hello?
പാർട്ടിസിപ്പൻസിന് അൺമ്യൂട്ട് ചെയ്ത് ആൻസർ ചെയ്യാം. പറഞ്ഞോളൂ.
Progression.
Q waves in V1 and V2 with mild ST in ST elevation in V4 and V5.
I think that's V4 and V5 minor. That's ST elevation anyway. It's not profound. It's not less than 1 millimeter. It's not satisfy the criteria for ST elevation. But you can Q wave is there. Definitely, that is very good finding. That is one. When you always see this ECG, you have to find 4 or 5 things in these ECGs. One is Q waves. Development of Q wave. Q wave can develop from 1 hour to 12 hours. So you can early develop 1 hour. So Q wave, then definitely there is a Q wave. Then QRS height. QRS height from V3 to V4, if you see, V5 also we see there is loss of QRS. R wave height is lost. That is another loss of QRS height, and with compared to that, the T wave will go up. The T wave height will go up. That is hyperacute T, and you can see the base of the T become wider and wider. So that's another finding, and there is subtle ST elevation. So this ECG is a earliest. There is a hyperacute T, Q wave. There is loss of R wave height, and there is subtle ST elevation, and there is reciprocal ST depression. And finally, you have to check for one more important thing. There is a reciprocal ST depression in AVF. You can see there is a slight ST depression in AVF. So this ECG not fitting the criteria for STEMI, but this is a hyperacute T. This is a occlusion. This is occlusive MI. The LED, if you do angiogram, LED will be occluded in this patient, but it will be less than 30 minutes. You can find all this difference in this ECG. There is a reciprocal ST depression in AVF, loss of R wave height. There is Q in that. There is increase T wave goes up with a slight ST elevation. So this is the ECG of early patient presenting with ECG. You can see in a patient with atypical chest pain also these findings are there or not. These 4-5 findings is there, or from at least 3 are there. Then you can keep him on observation and see whether this ECG have an evolving change. So this is the same thing I have told you. The T wave, one in a hyperacute T wave, the T wave base will get wider. This is why it will be wider, it will be tall, and it will go above 25% of the QRS. As time goes on, this will cross the QRS, and then the ST segment become elevated. And this you can see this the J point, this S wave. You can see the S wave here. This S wave, and this ECG after 50 minutes, this S wave is being pulled up. This S wave is being pulled up, and the T wave going high, and the QRS height is coming down. If this happens, this is a evolving MI. This is hyperacute T. This is an anterior STEMI. This is very important finding. This is the earliest finding we can see, because loss of R wave height, the S wave being pulled up, and the ST segment and T wave forms a dome shape, forming the earliest elevation. And the Q wave formation. This lead, you can see the Q wave formation and the ST elevation. So this is the earliest things you will be seeing. I think I hope everyone understood. This already I told you. The ST will be convex upward because because of the S wave, ST segment. This ST segment make a dome with the T wave, and the T wave thus the T wave widens and becomes symmetrical and called hyperacute T wave. And this T wave can sometimes this may not be fully occlusive. Some flow will be there. So the T wave, biphasic T wave will be there, like this. This is a STEMI finding. This is going to be a STEMI. This is the ECG. Can anyone tell me the findings? From this, whatever we talk, anyone can find anything abnormal in this ECG? Let understand the minute changes coming into the ECG. Rest, I think, is very easy to identify this STEMIs, because earliest finding is usually we needed for the salvaging the maximum amount of myocardium. Can anyone unmute and tell the findings? You can tell just about the T wave, ST, QRS height, all those things.
V2 and V3, there is hyperacute T wave and subtle ST elevation.
Yes.
In lead 3, there is
Reciprocal
wave
this is a clear cut
more than
evolving myocardium.
Q wave that is more than 25% wave.
Not clear actually. You got told correctly, fully clear. This is anterior volume myocardial infarction. The same findings I told you. There is a loss of QRS, and there is a S. In V4 we can clearly see the S wave being pulled up by the evolving ST elevation, and the T wave is bigger, almost same equal as that of the QRS. So it's hyperacute T, is wide based, and there is formation of Q wave inferior, and there is corresponding reciprocal depression changes at the inferior leads. So that's okay. Then this is a 63-year-old smoker, chest pain 3 hours. Any specific findings in this patient? Is this normal or is this anything abnormal?
Bradycardia.
Yes, bradycardia.
V2, V3, V4. Hyperacute wave.
Yeah, same. This is also the same like the previous ECG, because this I'm seeing repeatedly, because we are seeing this. We'll see all these things in a clinical practice. We'll have doubt on diagnosing, so we should see all the 5 points to confirm it is hyperacute, is hyperkalemia, or if it's hyperkalemia. Also will have this hyperacute like T wave. So you should see the R wave height, QRS, that S wave will be pulled up like that. Yes, loss of QRS height, Q formation of Q wave, then corresponding ST depression in the opposite facing leads. It's also same. So there is some ST elevation also there in this V6. This one, anyone try this one? This is another interesting ECG. This one, till now we see a anterior myocardial infarction evolving as well. There is 30 minutes, 2 hours, 3 hours, like that we have seen. Now, anyone can tell this ECG what is the findings and what is the diagnosis? How will you differentiate? And see all the 5 points I told you to diagnose the STEMI in this patient. Q wave, QRS height, ST segment, then T wave, like that. All three components plus corresponding ST depression, like that. If you apply all these 5 things in a patient with ECG in these leads, you can almost certainly diagnose. You will never miss a myocardial infarction in the ECG.
ST elevation 2, 3, പിന്നെ ST depression, AVR. പിന്നെ AVF-ല് ST elevation ഉണ്ട്.
Okay, inferior lead there is ST elevation. Then any other areas ST elevation?
V4, V5, V6 ST elevation.
Okay. The V3 also, V3, V4, where there also ST elevation is there. 1 AVL also there is ST elevation. There is everywhere there is ST elevation. So then you have to see all the other 5 points, whether it's infarction or not.
Is it supraventricular?
It's a tachycardia. It's not supraventricular tachycardia. Sinus tachycardia only. It's P followed by QRS. Everywhere P is seen. Sinus tachycardia. There is ST elevation, global ST elevation is seen. And you can see the ST elevation pattern. I already told you ST segment will merge with the T as a dome. That is convex up ST elevation. In this, you are not seeing that convex up. It's not merged as a dome. It's merged as a U. So it's not a typical ST elevation we are seeing. Then what are the other points of ST elevation? Other 5 points. Any loss of QRS height from V1, V2, V3? We are seeing serially going up. No loss actually. No loss of QRS. There is you see the S wave. S wave is not affected at all. And the ST segment is not like a convex support. There is no reciprocal ischemia pattern of T wave or a QRS or Q wave. Nothing, no Q wave also is not there. And you are seeing some PR depression also. So this is a pericarditis ECG. I think you are following. Hello?
കേൾക്കാം.
It's a pericarditis ECG. There is a global ST elevation and concave ST elevation. And there is no loss of R wave. There is no Q waves in this. There is no reciprocal ST depression. And AVR, that ST depression is not taken as a reciprocal in this case. And this clinical syndrome in a 28-year-old with chest pain, if you don't, they will have chest pain in lying down position, respiration, aggravation, and with the history of fever or elevated by ESR. All of those things will tell you it's a pericarditis. And you can see this ST elevations will usually never cross 1 large square, 5 millimeter. Because it's not a transmural. It's a pericardium plus some area of epicardium is affected. So with inflammation. So the electrical activity will be in that area. Because it's inflammation, but not transmural. The height of the ST elevation will not usually cross 5 millimeter. So this is a non-infarction pattern ECG. This is a mimic, a STEMI mimic. Okay. So you have to see all the 5 points. Usually in anterior leads mainly, in other leads also you have to see. You have to see the loss of heart rate. All you find, if you just remember that 5 points, you can confidently tell it's not a myocardial infarction. And you see, of course, you have to see the patient, you have to see the biomarkers also. But ECG will give you confidence to treat the patient with some anti-inflammatory. So in this ECG, you can see the pericarditis in this area. There will be concave ST elevation. Then this is like a dome. Dome is formed, but this is not a dome. There is a concave from the J point. There is a concave upward. Then will be PR depression will be there. Then STT ratio will be more than 25%. Because T wave will be high. That will not rule out this one. You have to see the other features also. You have to see all the 5 points I am usually starting telling from the first itself. This ECG, can anyone tell the diagnosis? Please apply the 5 points I told. You just tell that and find out what is the problem. Can anyone volunteer? try to apply it. You will be very confident doing it. Very easy, it's handy. You don't have to remember to think about it. If you do some 5-10 cases, it will come automatically. Hello?
Anterior volume.
Yeah. Why it's not pericarditis? Because there is a diffuse ST elevation everywhere. A PR depression is there. What are the 2 points that helps you to tell it is anterior volume? There will be inferior wall, there is concave upper ST elevation also. Can you tell 2 points there is glaring at you to tell that it's MI with 100% surety?
V2 to V4 convex.
That's one. Okay. And the important 2 things.
4 R-wave progression.
Yeah. Loss of R-wave height. Like that you have to tell. Loss of R-wave height, QRS height. Then you can see how this is going up. This ST being pulled, this S wave is being lost. Because this T is going up. This is one. This pulled up like this. Dome like ST elevation, loss of R wave. So this is 100% STEMI. It's not pericarditis. Some STEMI will also have associated pericarditis also. This is the way you have to find out the MI with the pericarditis. Okay, it's a case of MI with pericarditis. This is 32-year-old with chest pain, 1 hour. Tropa is negative. This is usually we see in young chaps, young male or middle-aged male with ECG. We see in the casualty, we will see ST elevations or what, any other thing. Can anyone tell the diagnosis? And you can apply all the 5 points and see whether it is ischemic or not. We have a lot more ECGs to tell. If just to tell what is if diagnosis is also enough, and we can just
J
find
point
out
elevation. J
Yeah,
point
yeah.
elevation.
J point elevation. And so this what kind of pattern? This male 32-year-old with a typical chest pain. Usually we see in ECG, the J point elevation is a benign early repolarization pattern. But what all way we can tell it's not ischemia? Because I tell what are the points against ischemia? What are the points towards ischemia?
R-wave progression is there.
R-wave progression is there. Then ST elevation pattern is not that much. There is J point is clearly seen. J point is clearly seen. S wave you can see properly here. But here it looks like S wave is a little pull up. Here. Okay. Then there is no reciprocal. So if you see this here, there is clear J point. Here clear J wave is there. There is S wave. You want only one for to diagnose benign early repolarization. Either clear J point or S, clear S. If both are there, it is 100%. Or if anyone is there, it is early repolarization. In usually MI, we usually see there will be no definite J point, or S wave will be pulled up like this. So in this, in all the ECG, either there is a S wave or either there is a J wave. So it's a 100%. What is benign early repolarization, middle-aged man, which is of no high risk feature in this ECG. Because benign early repolarization usually thought was normal, but it can it is a channelopathy, can lead to arrhythmia if high risk features like if all STT changes are in inferior, anterior, lateral like that. So with family history of palpitation, sudden death and all, it's important. But in usually it's a benign variant in limited leads. You can definitely identify this one. In this, the last 3 row, you can see there is a notched J point, slurred J point, and well demarcated J point. If you seeing a J point, is usually or S wave, definitely S wave in this one. You can see in anterior volume there is no S wave, no J wave. Here S wave is there, J wave is there. So this is early repolarization, but this can be ischemia. You can't roll out ischemia in this. You have to see other features, QRS, loss of QRS height, all those things for diagnosing. It's a ruling out MI in this case. But in this case, J wave is there, S wave is there. So it's 100%. 100% say early, benign early repolarization. Okay, early, or either you need only S wave or only J wave also, it's okay. If both are there, it's okay. Like that, you have to rule out early repolarization, mimic of STEMI. Can anyone tell the diagnosis of this patient? 65-year-old, maintenance hemodialysis. After dialysis, present, before dialysis, present with vomiting and giddiness. What is the diagnosis?
Hyperkalemia.
Correct. Very good. This hyperkalemia. This also it looks like hyperacute T waves. What are the things usually we will see we used to rule out this hyperkalemia, hyperkalemia hyperacute T waves?
Metric T wave.
No, this is T wave upright only. No? Upright T wave only. Ended. It's like a pulled up T wave. It's not like a broad based. It's not like a dome. Okay. It's like first difference is that it's not like a dome. It's like a peak. Spin. It's a point. It's pinch like. Then QRS height will be preserved. There will not be Q wave like that. Then reciprocal depression you can see in because of the depolarization abnormality. That's all not because of the T mainly by the T wave QRS duration, S wave. Those things I have used to tell like Q wave followed by QRS loss of QRS height, S wave pull up, dome shaped ST elevation, then broad and tall T wave. These are the early features you see in MI, but none of the features are seen in this ECG. There is no ST. There is some ST depressions we are seeing, but all that are all T wave higher than the QRS, where we are seeing that changes. So it's more of a history is more of a hyperkalemia. It's not a myocardial infarction. So this is the another ECG. Can anyone tell the 50-year-old atypical chest pain, discomfort, and vomiting? Is it MI or is it something else? This is not any high risk problem because ECG looks not very alarming, but there are subtle changes so that if you do a troponin, it will be positive. Can anyone tell the diagnosis? Can just see the findings also is enough. No, don't have to localize it.
ST depression in inferior leads.
Yeah, that's there. You are seeing any ST elevation or some anywhere?
ST elevation, AVL.
AVL and 1 we are seeing. 1 AVL, 3 we are seeing, and V2 also we are seeing loss of R wave, Q wave in V2. This is a classical of diagonal occlusion. 1 AVL ST elevation, inferior ST depression with Q in V2. This one is a classical of that South African flag sign like that you described. Because this abnormality we are seeing in can be connected one to this from here to here and this to like this. So this is South African flags V2 loss of R 1 AVL ST elevation, 3 ST depression. This is an isolated diagonal occlusion. So this is usually missed because this is not satisfying the criteria of STEMI by definition, but this is an acute occlusive MI. This is why we usually this MI can be missed. Okay, because you're not seeing much, but you have to see thoroughly into it. Then only you will find out corresponding areas because there is no contiguous leads changes in this. There is 1 AVL, 2, 3 V2. So this is all out of our usual STEMI criteria. So you shouldn't miss all these things. Next is this is very important. You shouldn't miss it. This is a major problem. So what will be the problem? It's a 68-year-old male, severe breathlessness, saturation falling 86. So whatever saturation falling usually is pulmonary edema. or COPD exacerbation. But in this patient, it's not like COPD history. So systolic BP is borderline 100 mmHg and he's tachycardic. So what is the finding in the ECG? What is the diagnosis? And how will you risk stratify the patient? What is the risk of the patient?
Pulmonary embolism.
No. This is a ischemia only. I think pulmonary embolism we not include. Miscellaneous session will include all those things. This one only ischemia only. Cardiac ischemia directly involving the coronary arteries.
Lateral wall MI.
No, it's not a lateral wall MI. You can just see all leads. Or when you look for MI, you can see in leads in group 2-3 AVF alone, V1 to V1, V2, V3 alone, V3 to V6 alone, 1 AVL alone. Like that, you can group and see. Then you will not miss it.
ST depression in 1 and AVL.
Yeah, that's there. Alone 1 and AVL, other V5, 1 and AVL, same area, V5, V6 also, we have to look. So that all this area we have ST depression. Okay. V4 also have V3, V2, all everything having ST depression. 2 also having, but 3 is having another finding. What is that?
ST depression elevation 3.
3 is ST elevation. There is AVR also having ST elevation. AVR.
Yes.
V1 also having ST elevation. So in this pattern, AVR ST elevation, V1 ST elevation with diffuse ST depression. But 1 AVL, V5, V6, 2 or diffuse ST depression. I will show the more prominent ECG. This is a subtle ECG. This also you shouldn't miss it. That's why I'm showing first itself. Because AVR ST elevation with the diffuse ST depression indicates global left ventricular ischemia. It will come from the occlusion of the left main coronary artery. So why there is ST elevation in 3 means there is already RC will be occluded. This right coronary artery will be supplied from the left. So this left is now having some thrombus and occlusion. So the most distal territory supplied by the left collateral is the RCA territory. So RC will be infected. So RC will show ST elevation. All the other leads will show subendocardial ischemia pattern. So all the other will have ST depression. AVR will have ST elevation. So this is a typical pattern of left severe 3-vessel disease. The patient will have pulmonary edema or cardiogenic shock. It's impending. His death is impending in this patient. So this patient you have to stabilize the pulmonary edema and you have to do the early angiogram. And these patients usually will go for coronary artery bypass grafting. I will show the another ECG. This is a more pronounced ECG. This is another patient because his heart rate is little higher. It's around 100. These findings are very prominent. Can you enumerate the findings and tell the diagnosis? This is a 56-year-old, diabetes, hypertensive, CKD, all those things are there. So his vascular health will be very bad. Can anyone tell the ECG and the diagnosis? Just I told you. I will tell you the pattern name also.
Lead 1, ST depression, and T wave inversion in lead 1, AVL.
Yeah, you can group and see 1 AVL, V5, V6. You see everything. Then 2, 3 AVF you see. Then V1 to V2, V1, V2, V3 to V6. Like that you have to see and record the findings.
ST depression everywhere except elevation in AVR.
Yeah.
And 3.
3 elevation AVR, V1 also, but AVR is more than V1. Okay. Then 3. This is the same thing I told you just now. Because RC occlusion, left main supplying the RC territory, but left main is occluded. Now with Ischemia or something. So this patient will be having a severe 3-vessel disease, severe compromised circulation to the heart. So this is called Aslanger pattern, severe 3-vessel disease pattern. Okay. The patient will be very sick because his heart is fully ischemic. He can go through into VT, he can have shock, cardiogenic shock. He can suddenly die. Pulmonary edema will set in. All those problems. So this is a very patient with a very sick patient. This EC tells you patient is very sick. This is diffuse ST depressions with the ST elevation AVR, V1 and 3 usually may have or may not have. But AVR ST elevation more than V1. Why is AVR more than V1 indicates LMCA? And V1 if more, then it is LAD proximal. Because AVR, because of the circ involvement, the V1 elevation is masked because circ is going posteriorly. The infarction in that area will mask the V1 elevation. That's why V1 is little smaller compared to AVR. So AVR elevation more than V1 indicates left main coronary occlusion. Left main coronary divides into left-handed descending and LCX. LCX going back to the back of the heart. So if that area also ischemic, V1 elevation will be masked. That's why V1 is lower. This is another case. Can you tell this ECG? Is it this ECG is put? This is a very simple ECG. Why this ECG is put? Because of the risk stratification, whether we want to thrombolize the patient or not. In this case, that's the question. 78-year-old, typical chest pain setting, stable hemodynamics. Patient is chest pain free. Intermittently, she's having mild pain. This patient comes to the casualty, whether we want to thrombolize or we will send to the PCA capable center for revascularization. This patient presents after 6 hours. Can anyone tell about this ECG findings? I can tell. Then you can tell the management also.
Inferior wall MI.
Yeah, not inferior wall.
ST elevation and V2, V3.
Yeah, V2, V3. This proximal depression, septal infection. Yeah, V2, V1 also having ST elevation, V2, V3 septal infarction pattern. Then a reciprocal ST depression you are seeing. This patient is hemodynamically stable. Thus, this patient needs a thrombolysis.
Q waves already emerged in
Only
V2.
Q waves.
Q waves are there, but Q waves can present from 1 hour to 12 hours. So Q wave will not make your decision correct. Can ask the patient always has index pain. That will be the most, you have to 3 things you have to see. Index pain, all those index pain. When you ask the index pain she's telling around 7 hours back. So this patient can because T started inverting. So this is like a Wellens pattern. Wellens pattern and LAD will be this all STEMIs will 50% will recanalize. So when they recanalize, pain will be decreased. There will be T starts inverting. So this patient will have some flow in the ST elevation. This point also you can, if they are complaining of chest pain, you can thrombolyze. But this patient profile is 78-year-old. So in advanced stage patient with stable hemodynamics, not just pain, and T started inverting, you can send for a PCA. PCA is better because it's 7 hours. After 3 hours, the advantage of thrombolysis fades away, and the advantage of percutaneous primary PCA goes up. If you can send the patient to the PCA capable center within 2 hours, that is the ideal thing you can do. If in a very remote place, we can thrombolyze the patient. But 78-year-old, they're carrying a risk of bleeding. This is actually 68-year-old with the setting. She had a baseline LBB ECG. She showed us. This is a typical LBB, but this ECG we repeated, and after 1 hour, can you diagnose what is the problem? This ECG, LBB ECG you have seen. This is how will you diagnose the MI in the LBB ECG? That's a theme of this ECG. You don't have to mark up everything about Scarbosa criteria. There is a modified Smith criteria. That's very easy to diagnose the LBB patient with the myocardial infarction. Can you tell the findings? I think you already marked in the ECG. In this ECG, you can see there is concordant ST. Usually, in this one, you are in the previous ECG, we are seeing the discordant changes. There is R wave followed by there is a T inversion, asymmetrical wide T wave. But once ischemia sets in, there you can see concordant ST change. In positive QRS, the ST start becoming ST elevation. In this negative lead, you can see concordant change. There is ST depression sets in. Negative, if you go, you can see the negative wave, there is no ST depression here. But in negative wave, there is your ST depression, and positive wave, they are seeing ST elevation. That is concordant change. And as well as discordant change when you assess, if this ST elevation goes more than 25% of the QRS height, that you are losing the QRS height and the ST going up. That is 25% of the more than 25% of the QRS height. This ST going up, then it's a MI in the LBB or as well as in pacemaker ECG. These two things you diagnose MI by two things. We are seeing the looking for the concordant ST changes as well as the discordant ST changes. That ST changes in the discordant lead is more than 25% of the QRS amplitude. You have seen this is a QRS amplitude, this is ST, this is ST amplitude. It's more than 25%. This is almost only from 10% or something. This is almost 25%. So inferior infarction. This is a way to find out LBB in myocardial infarction LBB. This ECG, can anyone tell? Hypertensive chest pain old ECG. This is old ECG. You can see a hypertensive LVH with a strain pattern. Because strain pattern, there is a ST depression with a asymmetric T wave inversion. T wave inversion is not too deep. It's less than 3 millimeter usually. It can go more than 3 millimeter, but usually it is less than 3 millimeter, 3 to 5. But this patient had its chest pain old ECG. We have a new ECG in the casualty. Can you tell the findings in the ECG? This is how a LVH patient with MI usually presented. Can anyone attempt this?
ST depression, 2 AVF, but
Like
an LV strain.
2, 3 AVF and 2 AVF, then
V2, V3, V4, V5, V6.
it's depression. But the T wave, can you tell what is the peculiarity?
Asymmetric.
The same patient ECG you see just 1 minute back. This T wave inverted. This guy is T is going up.
അങ്ങനെയാണെങ്കിൽ നമ്മള് പിള്ളേരെ ഇഞ്ചക്ഷൻ എടുക്കാൻ പറ്റുന്ന എവിടെന്നെങ്കിലും കാണിക്കുന്ന നല്ലത്. ജില്ലാ ആശുപത്രിയിലോ അല്ലെങ്കിൽ ICHലോ അല്ലെങ്കിൽ പ്രൈവറ്റ് ആയിട്ട്.
Can anyone read the ECG? This is actually subtle going to ST elevation. This is an STEMI pattern. It can be, it is associated with increasing T wave height corresponding to the R wave height. QRS coming down, R wave going up. There is ST depression and corresponding ST depression in inferior leads. It is anterior MI evolving. In a patient with LVH, it will not be like a patient. You have to see the old ECG, you have to see the new ECG. When the old ECG patient, where there is ST depression and there is T upright T, there is discordance in the ST wave and the T wave, then you should be very careful in these patients. The hypertensive patient with LVH. So discordance in this ST depression, there is concordance is there. ST depression with the concordant T inversion. But in this way, ST depression with the discordant T wave, this is highly suggestive of ischemia with the reciprocal changes in other leads and reward myocardial infarction. This is the same thing I am telling you. This when you find a T wave abnormality, you have to find out ST segment depression, QRS concordance, ST segment depression, T wave inversion concordant with QRS suggestive ischemia. ST segment depression with an upright or biphasic negative positive in search of ischemia, biphasic or negative positivity, and positive negative biphasicity with a minimally elevated J point. All these things you already seen. All this ECG is self telling you it's a deep T wave plus some J point elevation ischemia. This all is T wave inversions is ischemia, but in LBB there will be segment depression and asymmetric T wave inversion secondary to left ventricular hypertrophy. This is benign. These are all ischemia. These are all T wave, biphasic, concordant, discordance with the ST segment, biphasic, then broad, deep, symmetric, polar, ischemia, T waves. This is 55-year-old, no prior cardiac history, present outside ED with the ongoing chest pain 2-3 hours, expected transfer delay 2 to 3 hours. So this patient will you thrombolyze? Does this patient require thrombolysis? Just we discussed it. Just I am refreshing you. Can you anyone tell the diagnosis? Which territory is involved? Does this this is recanalized or this is totally occluded MI? I think from 2, 3, 4 more slides are there.
Yes.
This is actually inferior. Tell me, hello?
No.
ST elevation 2-3 AVF.
Yeah, ST elevation is there. Then there is a T wave inversion also there, biphasic T. Q is there. So this has happened a little back. Q wave is there. So it's in some the age of the infarct can be very wide range, but with 2 to 3 hours back. So this Q is early Q, and there is T inverted. So this patient need not be thrombolyzed. You can transfer him to PCK center for because it's not a high risk. It's already flowing because T is started inverting. The reciprocal depressions are gone. So this patient you can transfer without any problem for PCI. If you want to thrombolyze, that also is possible because it's 50 for no content is for thrombolysis. For these findings are seen, we can with stable hemodynamics, no arrhythmia, then with stable blood pressure, we can send. This is the one. This does this ECG. This patient, 71-year-old, end-stage kidney disease. After 24, 1 day after he presents. Does this needs any thrombolysis? Does this Q wave is like Q wave just I showed you?
Deep Q wave.
Deep Q wave and relates. This is evolved interval MI. This is 30-hour-old MI. This doesn't qualify for reperfusion strategies. So this type of QAMI, he will have severe LV dysfunction, ventricular aneurysm like that. So this needs medical management, diuretics, and this antiplatelet statins, AC inhibitors like that to stabilize his LV to prevent his LV adverse remodeling. Even if you do PC also, this LV myocardium is will not usually recover. This will be transmurally infected myocardium.
Why it doesn't need stent?
Because this myocardium is also already, this microcirculation is already damaged. If you put a stent also, microcirculation, that myocardium is not perfused. He will develop only TME2 flow or something. So in that case, this revascularization, unless he is having chest pain, you have to do. If no chest pain, totally asymptomatic, just supportive care is enough. This patient usually, what happens, they will recanalize spontaneously this territory, and they will have a little perfusion in whatever myocardium which is viable. So they will maintain the myocardium. If they have chest pain, then you have to do angioplasty. Otherwise, there is no role in doing angioplasty because microcirculation is already clogged. So you have to give heparin, give all antiplatelets, statins, and a goal-directed heart failure medical therapy. Usually they will recover. with some reasonable LV function. This patient, if you do stenting also, that is not worth for saving myocardium, because already myocardium is lost. But you have to do angiogram. You have to do angiogram and see whether this patient having a collateral from the other side, preserving the function, LV function. And you can see cardiac MRI, whether the transmural infection can happen or not. Or 50%, less than 50% of the myocardium thickness is preserved, then you can do revascularization. So these patients directly not qualify for the primary PCI. We can do it angiogram, risk stratify, assess the risk benefit ratio, and do the revascularization later. So these are bad Q waves, late, very wide and very deep Q wave, especially in the anterior territory. Early Q waves, if you do, these patients, if in this inferior column early Q wave, if you revascularize, this Q wave will disappear because it's not transmurally infected. It's due to stunning, it comes, Q wave. So that stunning we can reverse with revascularization. So these small, short Q waves will go, early Q waves will totally disappear and later. But like this deep, wide Q waves present after 24 hours will stay there.
ഇതിൽ ക്യൂവും നമ്മൾ എങ്ങനെ തിരിച്ചറിയാം?
ഏതാ?
ക്യൂവും എസും തമ്മില് എങ്ങനെയാണ്?
ക്യൂ എവിടെയാണ്? എസ് അല്ലേ? ക്യൂ എസ് ആണോ?
അതെ, ക്യൂവും എസും എങ്ങനെ ഡിഫറൻഷിയേറ്റ് ചെയ്യും?
ക്യൂ എന്ന് പറഞ്ഞാല് QRSന്റെ ഫസ്റ്റ് നൈറ്റ് ഡിഫ്ലക്ഷൻ ആണ്. എസ് വേവിന്റെ ബേസ് ലൈൻ എന്നുള്ള ബേസ് ലൈനിലേക്കുള്ള പോസിറ്റീവ് ഡിഫ്ലക്ഷൻ ആണ് എസ് വേവ്. ക്യൂ എന്ന് പറഞ്ഞാൽ ഫസ്റ്റ് നെഗറ്റീവ് ഡിഫ്ലക്ഷൻ. ഇത് ക്യൂ ഫസ്റ്റ് നെഗറ്റീവ് ഡിഫ്ലക്ഷൻ. എസ് എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ QRS കഴിഞ്ഞിട്ടുണ്ട് എൻ പാർട്ടാണ്, അതിന്റെ നെഗറ്റീവ് അസെൻഡിങ് ലിംബാണ്. ഇതാണ് എസ് വേവ്. ഇത് അസെൻഡിങ് ടുവേർഡ്സ് ST സെഗ്മെന്റിലോട്ട്. ക്യൂ ഇവിടെ, എസ് ഇവിടെ. Q first negative deflection of QRS. S എന്ന് പറയുന്ന terminal portion of the QRS complex. QS എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ പോസിറ്റീവ് ഒന്നും കാണത്തില്ല. Q ഒരു അസെൻഡിങ് വേവും ഒരു ക്യൂവും കാണും. ഇത്ര മാത്രമേ കാണത്തുള്ളൂ. ഇത് QS പാറ്റേൺ. QS 51-year-old with angina. What is the diagnosis? Is it a STEMI or it's an STEMI? This is another STEMI patient, but this is a posterior wall MI. It's a circ occlusion. Posterior wall MI, you will see ST elevation in subtle ST elevation in inferior lats, prominent ST depression V1, V2. When you see prominent ST depression in V1 to V2, it will be posterior wall. It have infection happen in the back of the heart. So if you keep a lead at the back of the heart only, you will pick up ST elevation. So you see a V7, V9 lead, you will see ST elevation, but V1, V2 lead see only ST depression and some ST elevation in the inferior leads also. So this is a true posterior MI. This is ST elevation MI, needs emergency and primary PCI for revascularization. This is another one you usually miss without seeing subtle ST elevation only. Prominent ST depression, usually can miss it. So we get to see V7, V9 leads to see there is a posterior wall MI. The only thing is prominent ST depression will be there with upright T. You can see prominent ST depression with upright T. This is there, then it is posterior wall MI. This is only obtuse marginal, left circumflex occlusion. This is another one, 50-year-old with chest pain and syncope. Usually chest pain with syncope usually indicates for bradycardia. What is the diagnosis? You will see. But anyone can tell the diagnosis?
Inferior wall.
Inferior wall MI, correct. What are other abnormality? Inferior wall MI, we say syncope. What is the cause of syncope in this patient?
Bradycardia. Hypotension.
Anterior wall.
Having RV1 solution, having RVMI, hypertension will be there. Then one more thing is there, cause of syncope. Hypertension patient will not go blackout usually. They will have fatigue and sweating and all those things. Blackout is one more thing you have to look. What is there? When P wave and QRS relation, you can see.
P wave is absent.
PO is there, but not related to QRS. So it's a complete heart block. Inferior LMI will have RVMI. If RVMI is in inferior LMI, you usually see these things pattern. Bradycardia, AV blocks. RVMI will have hypotension, severe hypotension, refractory hypotension only response to fluid. So these things, inferior LMI, you will see all these findings. Again, we will have ST elevation in 2-3 AVF. This 2-3 AVF elevation can happen in SIRC MI also. We will see how to localize SIRC and this is RVMI. You can see inferior wall in V1 ST elevation. But RCI is LCX infarction. How will you find out? That's one thing you have to understand. Then our right coronary artery, you can see the injury vector will be pointed towards 3. Because injury in the inferior, 3 is looking at this area. But in SIRC, it is going to lateral. It is injuries away from 3 towards more towards 2 and 3. When the inferior infarction occurs, right, RCA infarction occurs, ST elevation will be more pronounced in 3 because it injury vector is towards 3. But in SIRC infarction, injury vector is more towards 2 or 1. So changes will be there in the 1 or 2, not in the 3. So first elevation is more on 3, it is RCA because right side. It's more on 2 with the 1 on AVL changes, it will be OM. SIRC, like that you have to find out. So this is in, you can see the ST elevation, this is 5 mm in 3, this is 3 mm in 2. So what will be the culprit artery, RC or L6?
RC.
RC.
RC, correct.
RC.
RC, correct. This one, which one? Which artery? 3 or 2? 3 is more, no? This is RCA. This one, which is more? 2 or 3? And 1A will you also have to look changes. This is which one?
Lead 3.
Lead 3. This 3 is not more, no? This 2 is lead 3 is 1.5. Lead 2 is 1.5. Okay, this is almost same. 2 and 3 are almost same. Then you have to see the other leads, posterior changes, posterior wall changes, because SIRC is going posterior of the heart. So V2, V3 is having ST depression. 1 AVL also will have some changes. V5, V6 also some changes. So in this, if you see the profound LV changes, then it will be like ST depression, V2, V3, posterior wall changes, inferior changes, lateral changes, then usually circumflex artery. So final thing, the diagnosis, just a diagnosis only. Where?
Anterior MI.
Anterior MI. What will be the prognosis? This acute occlusion, this tombstoning like ST elevation. So this patient needs emergency revascularization. He will be in shock. This will be like tombstone like ST elevation, very huge ST elevation. It's anterior MI. Oh, I think we completed today's ECG. Any questions?
ചാറ്റ് ബോക്സിൽ ഒരു ക്വസ്റ്റ്യൻ വന്നിട്ടുണ്ട്. ഹൗ early the Q wave can develop in a STEMI? When Q waves develop, can we thrombolyze if pain is short duration?
Q waves can develop early. Previously, we thought it's a sign of a late presentation, but Q waves, short Q waves, not long Q waves. Early Q waves can develop from 1 hour to 3 hours, and it can develop up to 14 hours. So it's all depend on the thrombolysis decision, depend on the index pain as told by the patient. Okay. And troponin level also you can give an idea. If troponin is 10,000, 25,000, it will be like a 12 over MI. Troponin start rising, it's in the ascending limb only, it will be 6 hours, 8 hour MI. Like that, troponin value also will give an idea. That's why I told you initially that graph I showed initially. That also will tell you when that happened. MI can happen. You can time the MI with that graph actually. That's I showed in that initially. Can you seeing this? Can you see this? Can you see the reperfused?
സ്ക്രീൻ കാണുന്നില്ല.
കാണുന്നില്ലേ?
ഇല്ല.
പോരാടാ. ഇപ്പൊ കേക്കാമോ? സ്ക്രീൻ പോസ്റ്റ്
കേക്കാം.
അത് ആക്ച്വലി ആ ടൈം നോക്കിയാൽ മതി. അതിന്റെ പീക്ക് വരുന്നത് എപ്പോഴും ഒരു 24 അവർ ആണ്. ചിലത് 124 അവർ കൊണ്ടാണ് പീക്ക് വരുന്നത്, നോൺ പെർഫ്യൂസ്ഡ് ആണെങ്കിൽ. ഇപ്പൊ പീക്ക് ആയിട്ടുണ്ടോ എന്ന് നോക്കിയാൽ മതി. സ്റ്റെമി കട്ട് ഔട്ട് എപ്പോഴെങ്കിലും ഒരു 10,000 12,000 ആ റേഞ്ചിലാണ്. അപ്പൊ അതിന്റെ ഒരു 3,000 ഒക്കെ ഉള്ളെങ്കിൽ ഇറ്റ് വിൽ ബി ഏർലി പ്രസന്റിങ് ആയിരിക്കും. ഇപ്പം വിത്ത് ക്യൂ വേവ് ആണെങ്കിൽ നമുക്ക് ഏർലി ക്യൂ ആയിട്ട് എടുക്കാം. നമുക്ക് ത്രോംബലൈസ് ചെയ്യാവുന്നേ ഉള്ളത്. എപ്പോഴും റീപെർഫ്യൂഷൻ നമ്മൾ ഫസ്റ്റ് ഇത് കൊടുക്കണം. പക്ഷെ 3 hours വരെയാണ് ത്രോംബോലൈറ്റിക്സിന്റെ മാക്സിമം എഫിക്കസി. അപ്പോൾ 3 hours കഴിഞ്ഞാൽ നമ്മൾ സ്മോൾ ക്യൂസ് വന്ന് തുടങ്ങിയാൽ എപ്പോഴും പ്രൈമറി പീസ് ആസ് അഡ്വാൻറ്റേജ് ഓവർ ത്രോംബോലൈസിസ് എന്നുള്ളതാണ്. അപ്പോൾ നമുക്ക് അങ്ങനെ ചെയ്യാൻ പറ്റുമെങ്കിൽ അത് അങ്ങനെ എപ്പോഴും ചെയ്യാം. ത്രോംബോലൈസ് ചെയ്യുന്നത് ഒരിക്കലും ഒരു നെഗറ്റീവായിട്ട് പറയാൻ പറ്റില്ല. ഇറ്റ്സ് ലൈഫ് സേവിംഗ് പ്രൊസീജിയർ. യു ക്യാൻ പ്രൊസീഡ് ഈവൻ ഇഫ് ക്യൂ ഇസ് ദേർ ആൻഡ് ടി വേവ് ഓൾടുഗദർ ഇൻഡെക്സ് പെയിൻ, T wave or Q wave plus trop T values. You can thrombolize the patient based on that.
ഒരു ക്വസ്റ്റ്യൻ വന്നിരിക്കുന്നത്, ഇൻ ഡയഗണൽ ആർട്ടറി ഒക്ലൂഷൻ 1 AVL ST elevation is not that prominent. അങ്ങനെയാണ് ചോദിച്ചിരിക്കുന്നത്.
അങ്ങനെ കിട്ടണമെന്നില്ല. അതെ നമ്മൾ സബ്റ്റിൽ ആയിട്ടുള്ള ചേഞ്ചസേ വരത്തുള്ളൂ. കാരണം ഇറ്റ്സ് ഓൾ ഡിപ്പെൻഡ് ഓൺ ദ സൈസ് ഓഫ് ദ വെസൽ. വെരി ബിഗ് ഡയഗണൽ വിൽ ഹാവ് 1 AVL big, very big. That's why that sign is made. 1 AVL B1 and 3. These 3 altogether picture you have to take, not one finding. If it's big vessel, big territory, big branches for that diagonal, it will be big changes will be there. One will be a very bad largest. So it depends on human. So the variations are there. So findings also will not be 100%. So relative.
പാർട്ടിസിപ്പൻസിനെ അൺമ്യൂട്ട് ചെയ്ത് how to make out myocarditis in fever cases.
That usually you can see the patient having features of cardiac failure with some non-specific STT changes or tachycardia, loss of R wave height. And then you should suspect myocarditis. There is no typical ECG changes for myocarditis. So cardiac failure patient developing cardiac failure newly, like elevated JP, pedal edema, basilar crackles, LVS 3 with some ST changes, non-specific ST changes or loss of R wave. Then you should take it as diagnosis MI. It's altogether picture, not single ECG finding will not tell you it's a myocarditis. Non-troponin, of course, troponin also.
പാർട്ടിസിപ്പൻസിനെ അൺമ്യൂട്ട് ചെയ്ത് ചോദ്യങ്ങൾ ചോദിക്കാം.
CKD patient on dialysis, ongoing dialysis chest pain, and ECG shows some changes. Am I audible?
Yes.
And the patient usually have LVH with the strain pattern already, and the pain is typical sweating, and the patient is on dialysis. We can't send the enzymes also. So how we can diagnose and how to go about?
That's why I told you the one ECG changes you can look for is discordant ST depression and T wave. T wave is going upright and ST depression deepens further and the QRS height goes down. Then you should suspect a myocardial infarction, especially in anterior leads. Inferior will definitely show some changes, ST elevations, or some high AV blocks or PR trends prolongs, or some intermittent AV block will be there. In that case, this all depend on the symptom and ECG. Enzymes usually won't help. If you want to do CKMB will help. CKMB will have elevation in CKM of these patients. And troponin, you can always
not
see
ST elevation MI. If it's an unstable angina or NSTEMI, how do we?
Also will have this ECG changes, but elevation, troponin elevation won't be there. You can see serial elevations, and delta is more than 20%. You can take it as a myocardial infarction. Because first troponin is some 600. Usually in that case, CKD will have 600 to 800 troponin when you do troponins. Next, if you do it's more than 3,000, some myocardial infarction of it. If next troponin is only 1,000 or some 900, delta is more than 20%. It's not a myocardial infarction. But this patient tend to have a high degree of coronary disease. So this patient you can always anticoagulate. Give a goal-directed anti-angiogenic therapy and dual antiplex statin. And if they develop refractory angina, then we can revascularize it. you shouldn't miss an acute MI in a CKD patient. Otherwise, you can always medically manage. We all medically manage these patients because the intervention also long-term prognosis in this patient is very bad. That's why medical management on stable angina is good enough for these patients. But you should actively search for subtle signs of STEMI in this patient, which holds true in whatever we told in all the small QAs, loss of RV height, pulled upgoing, this broad T waves, all those things.
Okay.
Lipoprotein A, LDL B, LDL in predicting cardiac disease practically.
What is LPA, LP and LDL?
LPA, B and LDL എന്നായിരിക്കും ഉദ്ദേശിച്ചത്.
LPA and LDL, then ApoB is having all three things. You can see, look for the patients is having this risk of myocardial infarction or risk of familial history of young myocardial infarction in the family. If these things are elevated, they are definitely having a risk for developing atherosclerotic arterial disease. But there is not a targeted therapy to LPA. Only LDL we can treat with statins. But targeted therapy to LP is not available till now. Newer drugs are coming, and there is some injectables are there that shows benefit in treating LPA, but they are directly attributable to developing atherosclerotic cardiovascular disease, stroke, all those things. LPA, LDL, and ApoB. These three things. You can check in all these young patients who develops MI. Or family history of MI, which are unidentified, all family members died early, unidentified cause. Then you have to check all these things.
What's the role of HSCRP in patients with family history? Quite often, patient brings the report of elevated
it's very non-specific actually. If you find it and the therapies trials are telling is improving the reduction in events, but we clinically will not use it HSCRP because it's very non-specific. No? If you put a cannula, if you get a thrombophlebitis, HSCRP will be very high. And so in hospital admitted patients, HSCRP is not useful. If you OP wise, if you're seeing HSCRP, to some form it will help, and some drugs like colchicine we can prescribe. Dapagliflozin also effective in reducing that inflammation, systemic inflammatory milieu. But in our practice, this HSCRP we are not using. So non-specific to tell on other risk factors. It's not
Sir, if a patient with family history without any comorbidities, young patient comes with a high elevated HSCRP, so we need to evaluate for the risk factors alone, or do we need to start with something?
No, actually, with the family history, then we have to go and do calcium scoring, CT calcium scoring, and find out whether is atherosclerosis there or not. If atherosclerosis is there, you should start statin. And if he's pre-diabetic, you can start dapagliflozin and gout nil. If there is no evidence of coronary disease in such a patient, you can leave it because HSCRP is, or you can see serially whether it's elevated. And if he's obese, definitely it will be elevated. In that patient, lifestyle modification, then this antioxidant omega-3 and that all things will help. In that patient, if you want to really investigate, don't treat with after only HSCRP. You go to next level, do TMT. Then you send for a CT calcium scoring, which take only 5 minutes to see, no contrast. If there is a calcium in this coronaries, then you should treat him. So there is don't blindly treat HSCRP. What?
Hello, ഒരു question വന്നിട്ടുണ്ട്. Sir, that ECG of 78 years old typical chest pain scenario, how do we distinguish Q wave and S wave in V2, V3?
Q wave and distinguish.
S wave in V2, V3.
It's already short now. But small q followed by R, then S. I think that very basic. So, okay. I think this presentation is this. Can you see the presentation? Can you see the slides?
Hello.
Can you see the slides?
ഇല്ല കാണത്തില്ല.
Zoom in screen sharing point.
നോക്കട്ടെ ഒരു സെക്കൻഡ്. ഇല്ല, co-host ആണ്, സ്ക്രീൻ ഷെയർ ചെയ്യാം.
ഷെയർ ചെയ്യാം. ഒന്നുകൂടെ നോക്കട്ടെ. ഷെയർ സ്ക്രീൻ. ഓക്കെ. ഒരു ആൻഡ്രോയിഡ് എം ഐ എടുക്കാം. ഇത് കണ്ടില്ലേ? ഈ രണ്ട് ECG കണ്ടില്ലേ? V2 ECG കണ്ടില്ലേ? ഇതിനകത്ത് Q ഇല്ല, ആക്ച്വലി R ഫോളോഡ് ബൈ S ആണ്. ഈ ഒരു നെറ്റ് ഡിഫ്ലക്ഷൻ S. ഇതിന് ST സെഗ്മെന്റ് ആണ് വരുന്നത്. ഇതിനകത്ത് നമ്മൾ അത് 15 മിനിറ്റ് കഴിഞ്ഞ് എടുക്കുമ്പോഴത്തേക്ക് ദിസ് എസ് ദർ ഇസ് ലോസ് ഓഫ് എസ് വേവ് പോയി, ടി വേവിന്റെ ഹൈറ്റ് കൂടി. ഇതാണ് ഒന്ന്. പിന്നെ അടുത്തത് ക്യൂ വേവ്. ഇതാണ് ഇത് QS ആണ്. QS V1 V2 QS. QS Q ആണ്. ഇത് Q വേവ് ആണ്. QS കോംപ്ലക്സ്. അതാണ് ഉള്ളൂ. QRS. First negative difflection Q, R wave, S wave, followed by ST segment, like triphasic wave. The S wave, Q, this is the Q ആണ്, full Q, or QS complex, ST segment. This is a Q, this is S, this is QS complex. Any further question? I think today's presentation was useful, and to get the feedback, then I can prepare like this.
Okay, ഒരു 2 ചോദ്യം കൂടെ വന്നിട്ടുണ്ട്. When is TMT important? പിന്നെ coronary artery calcium score. Coronary calcium in CT angiogram യൂസ്ഫുൾ ആണോ അല്ലയോ ഇൻഡിക്കേഷൻസ്?
അതെ, അതിനകത്ത് നമ്മൾ TMT എപ്പോഴും പറയുന്നത് ഒരു പേഷ്യന്റിന് പ്രീ ടെസ്റ്റ് പ്രോബിലിറ്റി നോക്കാൻ വേണ്ടിയിട്ടാണ്. അതായത് പേഷ്യന്റിന് റിസ്ക് ഫാക്ടേഴ്സ് ഉണ്ട്, ചെസ്റ്റ് പെയിൻ ഉണ്ട്, പക്ഷെ ചെസ്റ്റ് പെയിൻ നോട്ട് ടിപ്പിക്കൽ ഓഫ് അഞ്ചേന, ഡൗട്ട്ഫുൾ ആണ്, അവിടെ ഒരു പെരിപ്പാണ് എന്നൊക്കെ പറയുകയാണെങ്കിൽ നമുക്ക് എപ്പോഴും പക്ഷേ റിസ്ക് ഫാക്ടേഴ്സ് ഉണ്ട്, ഡയബറ്റീസ് ആണ്, ഹൈപ്പർടെൻസീവ് ആണ്, അങ്ങനെ ഉണ്ടെങ്കിൽ നമുക്ക് ഒരു ഇസ്കീമിയ ഉണ്ടോ, ഇൻഡ്യൂസിബിൾ ഇസ്കീമിയ ഉണ്ടോ എന്ന് നോക്കാനാണ് TMT ചെയ്യുന്നത്. അതായത് പേഷ്യന്റിന് അറ്റിപ്പിക്കൽ സിംറ്റംസ്, ടിപ്പിക്കൽ അഞ്ചേന യു ഡോണ്ട് ഹാവ് ടു, അത് വേറെ രീതിക്കാണ് TMT ചെയ്യുന്നത്. അത് നമുക്ക് എഫർട്ട് ടോളറൻസ് നോക്കാനും ഇസ്കീമിയ ബേർഡൻ നോക്കാനും ഒക്കെയാണ് അത് നോക്കുന്നത്. ഇസ്കീമിയുടെ സിവിയർ ആണോ എന്നൊക്കെ അറിയാനായിട്ട്. അല്ലാത്തുള്ള ഒരു പേഷ്യന്റ് ഡയഗ്നോസ്റ്റിക് ആയിട്ട് ചെയ്യുകയാണെങ്കിൽ ഇങ്ങനെ ഒരു അറ്റിപ്പിക്കൽ ആയിട്ടുള്ള ഒരു പേഷ്യന്റ്, അറ്റിപ്പിക്കൽ പ്രസന്റേഷൻ, നമ്മൾ ECG എക്കോ എല്ലാം നോർമലാണ്, അങ്ങനെയുള്ള കേസിൽ നമ്മൾ TMT ചെയ്യണം, ഇൻഡ്യൂസിബിൾ ഇസ്കീമിയ ഉണ്ടോ നോക്കാനായിട്ട്. അങ്ങനെ വേറൊരു ഇതിൽ വാൽവിനൊക്കെ ചെയ്യാറുണ്ട്. വാൽവിന് നമ്മൾ എഫർട്ട് ടോളറൻസ് നോക്കാനാണ് ഇസ്കീമിയ ചെയ്യുന്നത്, അല്ല ഈ TMT ചെയ്യുന്നത്. അങ്ങനെയുള്ള പേഷ്യന്റ് നമ്മൾ ഇസ്കീമിയ നോക്കാനല്ല, വാൽവിന്റെ ലീക്ക് ഒക്കെ ഉള്ളവർക്ക്, റെഗജിറ്റേഷൻ, മൈട്രൽ റെഗജിറ്റേഷൻ, അയോട്ടിക് റെഗജിറ്റേഷൻ, അയോട്ടിക് സ്റ്റീനോസിസ്, ഇവർക്കൊക്കെ ആ എഫർട്ട് ടോളറൻസും BP-യുടെ റെസ്പോൺസും എക്സസൈസിനോടുള്ള റെസ്പോൺസ് നോക്കാനാണ് ട്രെഡ്മിൽ ടെസ്റ്റ് ചെയ്യുന്നത്. പിന്നെ അരിത്മിയാസ് ഉണ്ടോ എന്ന് നോക്കാം. ട്രെഡ്മിൽ ചെയ്യുമ്പോൾ നമുക്ക് അരിത്മിയാസ് എന്തെങ്കിലും ഡെവലപ്പ് ചെയ്യും. പേഷ്യന്റ് സിങ്കോപ്പ് ഒക്കെ ഉണ്ടെങ്കിൽ, അരിത്മിക് സിങ്കോപ്പാണ്, എക്സേഷണൽ സിങ്കോപ്പ് ഒക്കെ ആണെങ്കിൽ നമുക്കൊരു TMT ചെയ്ത് നോക്കുമ്പോൾ ആ സമയത്ത് അരിത്മിയ വരുന്നുണ്ടോന്ന് അറിയാം. എക്സേഷണൽ സിങ്കോപ്പ് വരാം ഈ HOCM-ലൊക്കെ. അങ്ങനെയൊക്കെ ഉള്ളതെങ്കിൽ അത് ECG ഡോക്യുമെന്റ് ചെയ്യാൻ വേണ്ടിയിട്ടും ആണ് നമ്മളിത് നോക്കുന്നത്. അതെ. അപ്പൊ പിന്നെ CT കാൽസ്യം, നമ്മൾ CT കൊറോണറി ആൻജിയോഗ്രാം എല്ലാ പേഷ്യന്റിനും ആവശ്യമില്ല. CT കൊറോണറി ആൻജിയോഗ്രാം ചെയ്യുന്നത് നമ്മൾ യങ് പേഷ്യന്റ്, ഒരു TMT ബോർഡർ ലൈൻ പോസിറ്റിവിറ്റി, പക്ഷേ നോട്ട് അമൗണ്ടിങ് ടു ഹൈ ഗ്രേഡ് ഇസ്കീമിയ, അങ്ങനെയൊക്കെ ഉണ്ടപ്പോൾ റൂൾ ഔട്ട് ചെയ്യാനായിട്ട് ചെയ്യാം CT കൊറോണറി ആൻജിയോഗ്രാം. പിന്നെ ഗ്രാഫ്റ്റ്, പോസ്റ്റ് CABG ഗ്രാഫ്റ്റ് സ്റ്റഡിക്കൊക്കെ CT കൊറോണറി ആൻജിയോഗ്രാം യൂസ് ചെയ്യാം. പിന്നെ യങ് ഫീമെയിൽസിനൊക്കെ ഈ എന്തെങ്കിലും കൊറോണറി ആർട്ടറി, കൺജനൽ ഹാർട്ട് ഡിസീസ്, സ്ട്രക്ചറൽ കൊറോണറി ആർട്ടറി ഡിസീസ് അതൊക്കെ ഉണ്ടെങ്കിൽ കണ്ടുപിടിക്കാനായിട്ട് CT കൊറോണറി ആൻജിയോഗ്രാം യൂസ് ചെയ്യാം. കൊറോണറി അനോമലീസ്, സാധാരണ ഉള്ള 3 ബ്രാഞ്ചസ് അല്ലാതെ അതിന്റെ ട്രാക്ക് ഒക്കെ മാറി വരുന്നതിലൊക്കെ CT കൊറോണറി ആൻജിയോഗ്രാം യൂസ് ചെയ്യാം. പിന്നെ ഇത് CT കാൽസ്യം സ്കോറിംഗ് പ്ലസ് CT കൊറോണറി ചെയ്യാൻ പ്രോഗ്നോസ്റ്റിക് വാല്യൂ 10 ഇയേഴ്സ് കഴിയുമ്പം അല്ലെങ്കിൽ 5 ഇയേഴ്സ് ആകുമ്പോൾ പേഷ്യന്റിന് ഒരു ACS ഇവന്റ് വരാൻ സാധ്യതയുണ്ടോ എന്നൊക്കെ പ്രെഡിക്റ്റ് ചെയ്യാനായിട്ട് ഈ CT കാൽഷ്യം സ്കോർ ഹെൽപ്പ് ചെയ്യും. മോർ ദാൻ 400 ഇസ് ഹാവിങ് ഹൈ റിസ്ക് ഓഫ് കൊറോണറി ഇവന്റ് ഇൻ ദ ഫ്യൂച്ചർ, അങ്ങനെയൊക്കെ പറയാൻ പറ്റും. സീറോ CT കാൽഷ്യം സ്കോർ ആണെങ്കിൽ ഇറ്റ്സ് എ ഗുഡ് പ്രോഗ്നോസിസ് ആണ്. പിന്നെ ഇനിഷ്യലി നമുക്കൊരു 10 കാൽഷ്യം സ്കോർ കിട്ടിയെന്നിരിക്കട്ടെ, ഒരു 2 വർഷം കഴിയുമ്പോൾ ഇത് 100 ആണെങ്കിൽ ഈസ് ഹാവിങ് എ ഫാസ്റ്റ് പ്രോഗ്രഷൻ ഓഫ് കൊറോണറി ഡിസീസ്. അങ്ങനെയുള്ള പേഷ്യന്റ് നമ്മൾ സ്റ്റാറ്റിൻ ഫുൾ ഡോസിൽ കൊടുക്കണം. അങ്ങനെയൊക്കെ ഉള്ള ആ ഒരു തെറാപ്പറ്റിക്കും പ്രോഗ്നോസ്റ്റിക് ആയിട്ടുള്ള കുറെ ഐഡിയാസ് ഈ കാൽഷ്യം സ്കോറിംഗ് നിന്നും CT കൊറോണ ആൻജിയോഗ്രാമിൽ നിന്നും കിട്ടും.
ഓക്കെ, നമുക്ക് വേറെ ചോദ്യങ്ങളൊന്നും ഇല്ല. നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം. ഇന്നത്തെ ക്ലാസ് തീർച്ചയായിട്ടും യൂസ്ഫുൾ ആണ്, ഇന്ററാക്റ്റീവ് ആയതുകൊണ്ട് തന്നെ. അപ്പം നമുക്ക് അടുത്ത സെഷനുകളും അങ്ങനെ തന്നെ പ്ലാൻ ചെയ്യാം.
അടുത്തത് നമുക്ക് ഇന്ററാക്റ്റീവ് ആയിട്ട് ചെയ്യാം, അങ്ങനെയാണെങ്കിൽ അത് പ്രയോജനമുള്ളൂ.
ആ, ഓക്കെ. നമുക്ക് ഇന്നത്തെ സെഷൻ എന്നാ വൈൻഡപ്പ് ചെയ്യാം. Thank you very much, Dr. Vishnu, for sparing the time and effort in teaching us. Thank you once more. We look again to meet you in the with another session.
Okay, sir. Thank you.
Thank you very much.
Thank you, sir. Okay.